everybody in here has seen a patient who's delirious. You might not call them that, but it's something that is ubiquitous in hospitalized patients. It's not just hospitalized patients that you see it in. People come into clinic. People come to the ED delirious all the time. Okay, so I got no disclosure other than we're going to talk about off-label medication use. Okay, and so hopefully you're going to learn something. Okay, hopefully. So let's just talk about, this is actually a real person. All right, this is Miss Loretta. That's not her real name, obviously. And she brings her mom in to see you in clinic, follow-up visit. And she's 81 years old. She's a retired school teacher who tells you right away this is a relatively well-educated woman. She was a school teacher, right? So she's not just a lady who lives underneath the bridge. She lives alone. And her daughter's found her at home incontinent and incoherent. And this is new since about the last couple of days. Okay, so this is a lady who's very well-spoken normally, who's got meticulous, regular hygiene and everything, would never be incontinent and disheveled like she is. So this is obviously an acute change for her, right? And, and so she's had a TI in the past, she's got hypertension, she's got GERD, she's got arthritis, and she's got sort of a chronic anemia, right? So not anything horrendous, sort of things that you see when you get older. And she takes lots of medicines. She takes metoprolol, she takes gabapentin, amlodipine, and a PPI. So when you're examining her, you don't really see anything too amazing other than she's bewildered. She looks at you like she doesn't really quite understand what you're saying. She doesn't really answer your questions. She kind of is like a 2-year-old that cannot be redirected. All right? And so, what's going on? What's the problem? So, the thing is that delirium is not new. Okay? So, the focus that we have on delirium is relatively recent in the last 10 years or so, but delirium's been known since the time of Hippocrates. So this is not a new phenomenon. This has been happening to people since when we got out of primordial ooze. And Celsius actually came up with the term back in the 1st century AD, and it comes from the Latin meaning to go out of the furrow, which means that you are deranged or you lose your wits. So some of the interns and residents who've been up long hours sometimes are delirious as you get ready to go on call, right? As just don't get enough sleep. And it is something that is acute. It has a sudden onset, has a fluctuating course. It's usually reversible, and that is not always true for somebody who's older. So frequently you'll have an elder who comes in delirious, who may never go home again because they no longer are able to care for themselves. It is onset minutes to hours to days, so it's not something that comes on over the course of weeks or months. It has a fluctuating course, usually better in the morning. So if you round on the patient at, say, 7 o'clock when the sun's up, and you go in to see the patient, they may be at G7-15, perfectly lucid, know everything that's going on. You have no question about them being in their right mind. Come 4 o'clock in the afternoon, the nurse calls and tells you, Miss Loretta has gotten out of bed walking down the hall naked, which Miss Loretta would never do. So as the day goes on, they tend to wane a bit, okay? It's got inattention. They can't pay attention. They have changes in cognition, perceptual disturbances, and sleep-wake cycle disturbances, okay? Sleep is really important. And when you don't sleep well, you can have problems with that. Most people recover completely, but not everybody. And usually it's triggered by something. Okay, so something happens to you that puts you over the edge. All right? So, quickly, comes on quick, hours to days. It has not dementia. So if you have an elder who becomes delirious in the hospital and you're talking to the family about these patients, they may not want to hear what you have to say because they may be worried that their loved one's now demented. You cannot diagnose dementia when somebody's delirious. Dementia comes on over a long period of time, obviously. You tend not to have perception change, although you do have behavioral changes. And so that's what I like to tell people. Okay, I can't tell you if your loved one's demented, but I can tell you that they're delirious. We need to get out of the delirious to figure out what's going on. It's not always reversible for elderly, and they can actually have long-term cognitive consequences even if you're not old. So there is a case study that's cited by everybody of a nurse who was in her 40s or 50s, an ICU nurse, who developed pylo, wound up septic in an ICU, became delirious, got over the pylo, got over the delirium. However, she had long-term cognitive issues and could never go back to work. So she had a really bad UTI, but she can't think well enough to be able to work as an ICU nurse. I went to an ICU Liberation Conference in Vanderbilt a couple months ago, and Wes Ely, who's done a lot of work with ICU delirium, called this ICU dementia. And that's like, wow. That was a really powerful thing, because this woman is not able to think properly. It's no longer applied for training, so something to think about. I also like to think about this as acute brain failure, because it kind of gives you an idea of how serious it is. If you have someone who's in acute respiratory failure, you're going to do something about that. You've got some pressing issue. You may put them on O2, BiPAP, intubate, ECMO, whatever. If they're in acute renal failure, you may consult nephrology and they may want to put CCRN or dialysis. But people don't really recognize how serious delirium is. So if you think about it as acute brain failure, that kind of gives you an idea of how big a deal it really is. Okay? So anyone can develop delirium. There are some people who are at more risk, but any one of us sitting in this room can become delirious, depending upon what's going on inside of you. You have some unwanted vulnerability. So if you are demented, you have a 100% chance of developing delirium if you're in the hospital. It's called delirium on top of delirium on dementia, or delirium on dementia. If you have some sort of CNS issue, you've had a stroke or a TBI or Parkinson's disease, something like that. If you've been exposed to some sort of toxin, something you gave yourself or something we gave you, you actually had a patient who became delirious after getting Benadryl for an appropriate indication. She had a rash. She went, BSC and had to be restrained, 4-point restraints. Or you're withdrawing from something. Or if you are old. The older you are, the more easily you become delirious. And age alone is an independent risk factor for developing delirium. So if you have Grandma Moses, who's 95 years old in the hospital, her chance of becoming delirious are awful good. You want to try and avoid that at all, okay? Then something happens, some medical issue, something, a UTI, car wreck, who knows, some medication, some environmental issue, or whatever, tips you over the edge and become delirious. Now, our ICU, our SICU, is a terrible place to be a patient. It's noisy, there's no privacy, and if you think about it, that bed is a 21 square foot isolation cell. Right? You can't get up and go to the bathroom. You can't get up and turn the lights off or on. You have no television tell you what time of day it is. You can't adjust the thermostat. You can't get a drink of water. You are in a 21 square foot prison. And so you can see how easy it is for patients to kind of slip into delirium really, really easily, right? Our environment sucks. Or we give them some medication. So something that nurses are really bad about is calling the intern saying, Mr. Jones needs something for sleep, can I get some Advil? Or Mrs. Jones needs something for sleep, can I get some Benadryl? Okay, out of the end, benzodiazepines is an independent risk factor for delirium. Benadryl has a lot of anticholinergic effects, another thing can cause delirium. So anyway, all right, so if you're old, if you have some sort of physiological stress, don't have to be in the ICU. You can be on the floor, you can be at home, you can be in the ED. If you have substance abuse issues, and that's not just alcohol or drugs, but also I think caffeine or nicotine. Because for some people, that can be a real issue for them, okay? Any comorbidities, any chronic illness, COPD, chronic heart failure, CAD, diabetes, any kind of neurological or cognitive issue, a brain injury, or a combination of all of those, puts you over the edge and into the delirium state, okay? So, things to think about. Do they have infection? Okay, most common cause of infection, unfortunately, in our institution is going to be urinary tract infection. All right, so we need to get folies out as soon as possible. So, infection. Do they have some sort of dehydration? But if you're on a 21 square foot cell and no one thinks to start you on the IV fluids, what's going to happen to you? Right? Because you can't get up a good drink of water. If you're sleep deprived, anyone been in the SICU at nighttime? It's not very quiet, is it? It's noisy, the lights are on, the nurses are trying to stay awake. I mean, nights are not good for anybody. And so our SICU sleeping in that environment is really, really difficult. But it's also difficult on the floor as well because you have people who go in and interrupt sleep. You always abuse people wait someone to be able to sleep with them. Really? If you're asleep, why would I give you sleep with them? If they are immobile, okay? So most people don't lay in the Jesus position, right? You walk in the SICU, how many times do you see people laying like this? Restraints, both arms, maybe on their ankles, laying flat on their back, maybe head that's elevated, maybe not. Yeah, I guarantee you walk in there, you'll find at least half people laying like that. Okay, that's not, the mobility is not good for you, okay? Restraints actually are an independent risk factor for delirium as well. If they're malnourished, so if you are tied to bed, you can't get up and go get peanut butter jelly sandwich, my favorite meal. So we need to make sure that people don't become malnourished while they're in with us. Folies and polypharmacy. No one in the hospital on single medicine. Usually they're on 2, 3, 4, 5, 10, 15. And if you're old, the older you are, the more medicine you should be on, right? Which is a problem. So no one misses the hyperactive delirium, okay? This is the classic delirium. It's the least common, it happens in less than 2% of the cases. This is a person who is hanging from a chandelier, he's swinging at people, he's pulling things out, he's getting out of bed. You do not miss this delirium, okay? But few people have that pure delirium. Hypoactive is a lot more common. Almost 44% of the patients will have hypoactive delirium. This is the one that's easy to miss because these patients are quiet. They lay in bed, they're withdrawn from the environment, they don't interact with people. And you don't really think about them being delirious because they're not pulling things out. So it can be really easy to miss these patients, okay? So no one misses this person, right? I love minions. But you might miss this one. Someone who's laying really, really quietly in bed who is actually delirious. And there's probably a subset of these people who are in a subclinical status epilepticus. So it's not a bad idea to think about, do I need to do an EEG to make sure they're not in status? But most people will have a mixed picture. They'll cycle between hypo and hyperactive. They'll be really, really quiet, and they'll be like the crazy man hanging from a chandelier. My dad did this when he had a shunt placed for normal pressure hydrocephalus. He would be all over the place, and then he would be like really quiet. Hardest thing I ever had to live through. You can also miss this. You may not really think about it. You might think that they're being psychotic or they've got dementia or something like that. And it's got a really bad prognosis. And you see this on 55% of patients will have this mixed picture. So you don't want to miss that, okay? This is sort of the Jekyll and Mr. Hyde. All right, so the problem is we don't diagnose it very well, all right? You can't look for something if you don't think to look for it. So depending upon what study you look at, and I've looked at a whole bunch of them, the prevalence is anywhere from 20 to 80% across the board for ICUs. You can see it up to 92% of people, trauma patients who are ventilated to develop delirium. But recognition rates suck. As low as 12%, but the highest recognition rate was 43%. Less than half of these patients are recognized as being delirious, which means you don't do anything about it because you don't recognize that that's a problem. It means that they are mismanaged 80% of the time. So if you think about 100 patients, only 20 people get appropriate treatment, all right? And there are about 2.6 million adults who are over 65, which will be me come December, who develop delirium annually. That's a whole bunch of people. Whole bunch of people, all right? So the problem is it's not a benign thing. You guys kind of get that idea here? So for every day you spend delirious, it increases your mortality by threefold that persists for up to 2 years after your delirious episode. So being delirious increases your risk for death. that lasts for 2 years after your delirium episode. So if you're delirious for a week, for 7 days, that increases your death by 21-fold. That lasts for 2 years. That's pretty serious. It increases your length of stay both in the ICU because you need to be ventilated longer because you're sedated, and in the hospital because you're in the ICU longer. It increases your ventilator and reintubation rates. But more importantly, there's a human cost. It's not just that the people taking care of these patients have problems, but patients have PTSD. These people actually remember the delirium episodes pretty frequently. And when you listen to how they describe it, it's absolutely bone-chilling. I mean, it really makes you feel like you're staying kind of crawl. Annual cost for delirium, more than $164 billion on healthcare costs. That's not chump change. That's a lot of money. Okay? So it means that they're at increased risk for nosocomial infections because they are restrained, they're not mobilized, they're intubated longer, they have Foley's longer. It increases your risk for long-term cognitive impairment, read ICU dementia, that you can see for more than a year after the episode. In some cases, it's going to be permanent. Okay? It increases your discharge to long-term care. That is nursing home. That's not a long-term acute care hospital. And may lead to a functional decline as well. So if you're an elder, and you develop delirium in the hospital, and you wind up going to your nursing home, you're almost dead 50% of the time within a year. So mortality rates in nursing home bound elders is 50% within a year. You don't want your mother, father, grandmother, grandfather in a nursing home, unable to take care of themselves. You're right. All right, so it's not a benign thing. So I'm going to run through the patho real quickly. I love patho, but I'm not going to belabor the point. The whole point is that we don't really understand it. It's very complex. It's not a single mechanism going to be in play for each particular person. There'll be a multitude of things that can be in play, and depending upon who that individual is, there'll be different types of pathophysiological components going on. These theories are complementary, not exclusive. So you can have more than one thing going on. Okay, so neuroinflammatory says that you've got some sort of inflammatory focus peripherally that winds up affecting your central nervous system. Basically is what it says. So it could be that you got this systemic disease that crosses your blood-brain barrier, causing a CNS effect. So think about patients who have high fever. You can become delirious with high fever. I had Tylo a few years ago, teaching pathophysiology with high core temperature. I didn't make any sense. I thought the class was great. So the students told me the next week, they didn't make sense for 3 hours. I thought for 3 hours, I had no idea what I was talking about. So that's neuroinflammatory. So, and we have lots of patients on trauma who have reasons for inflammatory responses. Neuronal aging, well, okay, so this is Dr. White. This is me, because if you're a trauma patient and you're 55 years or older, you're elderly. Okay, I don't feel old, but so as you get older, you simply don't have the resilience or the compensatory mechanisms that you did when you were younger. That's just part of it, it's just the way it is. And so that as you get older, you don't have as many stress-regulating neurotransmitters, your blood-brain flow decreases, you get a decreased vascular density, and it's problems being able to transduce systems in the brain so that you lose track of reality pretty easily. Oxidative stress, talking about O2-derived O2 free radicals, so that if you have a cerebral metabolic defect, you may see delirium as your clinical expression. Okay, so that if you have someone who's got tissue damage, trauma, surgery, or hypoxia, ARDS, or being dead for a little bit, severe illness or infection, all those things increase O2 consumption and or decrease O2 availability and can lead to this cerebral metabolic defect. Now, neurotransmitters, okay, there's a jillion of them, really, in the brain, and if they become unbalanced, or if you have higher levels of one than another, that can cause problems with the way the brain works. So things that you see when patients who have delirium are decreased levels of acetylcholine. you'll see increased anticholinergic function. So could be because you got a decrease in your cholinergic transmission or an increased dopaminergic transmission. You can see problems with the glutamine and GABA. Glutamine is the accelerator, GABA is the brakes, right? Glutamine is really an excitatory neurotransmitter. GABA helps to be inhibitory, keeps you gazing on the table at the bar. GABA will be working. So what you see usually frequently in these patients, they have decreased acetylcholine, will have increased dopamine, norepinephrine, glutamate. Dopamine is important because when we talk about some of the things that we do to help treat the behavior that you see with delirium, they are dopamine antagonists, right? And valproic acid decreases glutamate, right? Or you see alterations either up or down, depends on what's going on in serotonin, histamine 1 and 2, and GABA. All right. Neuroendocrine says that you've got only high glucocorticoid levels, which really is kind of counterintuitive, but actually causes some problems with inflammation. And so if you've got high glucocorticoid levels, then you can have problems with pro-inflammatory effect, which seems kind of weird, but also problems with ischemic and seizure-induced neural damage as well. Diurnal dysregulation is the word melatonin. Proper sleep-wake screw-ups. You don't know if you're supposed to be awake or asleep. How do you know what time of day it is? Anybody know? Well, the sun helps you, light, right? But you have a circadian rhythm, and because you cycle on that circadian rhythm, you kind of have an idea of where you are in the daytime, right? So you know that it's lunchish, noonish or whatever right now. But think about someone who's trapped in that 21 square foot prison in the ICU. With the blinds closed, lights off, no way to look outside to see if it's day or light. So it's pretty easy to get disconnected from whether it's daytime or nighttime, especially when it's louder at nighttime than it is in daytime sometimes. So people in the hospital, and not just ICU, but in the hospital, have severe alterations in their sleep-wake cycle. They have very fragmented sleep. They have very disorganized sleep. If you look at people who have had sleep studies while they're in the ICU, people in the ICU less than 3 hours of sleep a day, and that's not 3 hours at one time. It's 2 minutes here, 20 minutes here, so it's very fragmented. And so, I went to Egypt, so I had a great time. But I had some sleep-wake cycle disruption because I had a very, very long flights going and coming, so that I didn't get a nice 6 or 7 or 8 hours of sleep in a row. I got an hour here, a couple hours here, and you know what? It kind of affects you. So you think about, that was just one day for me. Think about some of the patients who are in the ICU, who've been there for 2, 3, 4, 2 weeks, a month, 2 months, how their sleep-wake cycle is really disrupted. And older people, a lot of times, they watch certain television shows that helps tell them where they are in time. So maybe they watch Good Morning America in the morning, and then they watch The Price is Right, and then they watch Jeopardy, and then the news. They kind of know where in the day they are by what's on television. Well, if you don't have a television that you can watch, or someone doesn't think to put it on the shows that you watch, it's easy for you to kind of lose track of where you are in the daytime, okay? And that your 24 internal clock is maintained by light exposure that impacts your melatonin production. And so melatonin, it not only regulates your sleep-wake, it helps to reset your circadian, but it's a free radical scavenger and helps reduce glucocorticoid activity. So one of the things that I tell people, I'll get that minute, all right. The last one is network disconnectivity, where the delirium is a failure of being able to integrate and process in sensory information and motor responses, and so the different parts of the brain simply don't communicate like it's supposed to. All right. So Miss Loretta, remember her? Came in, she was confused and everything. So she probably had a UTI, so neuroinflammatory. She was old, and she probably had some network disconnectivity going on as things that were underlying what was going on with her delirium, okay? All right, so this is a purely clinical diagnosis. There is no test to do to say, oh, Nick is delirious, okay? You do diagnostic tests to help you figure out, is there something I can do to help the problem? So if you have somebody that you think is dehydrated, doing a chemistry panel may help you figure out how to give the patient some fluid. Or if you have someone who's had a fall or whatever, you do a CT scan to make sure they have an extension of their bleed. So those diagnostic tests you do help you eliminate things that you can do that might make the issue better. But it's a purely clinical diagnosis. In order to be able to find it, guess what? You have to look for it. Okay? Things to think about. I've already said all that. All right. So think about it. If the patient is agitating, this is new onset, or the patient is confused, or if they're trying to get out of bed inappropriately, or pulling things out, or hitting people. Is it an acute problem? Could it be delirium? Remember that air condition rates suck. So at least think about, if this patient was not confused this morning when I saw them on rounds, and now they are, is this patient now delirious? And the answer could be yes. All right? So things that can be possible called, for instance, any drug that you can give the patient can possibly cause delirium. However, opioids are a big factor. Having said that, if the patient has pain, it's reasonable to give them something for pain to see if that helps their delirium, because pain can make you delirious. So it's reasonable if you have someone who's got 2 broken legs, broken pelvis, and 2 broken arms, to give them something for pain to see if that helps their delirium. If it doesn't, well, you know that's not the problem. If it does, then you know, okay, they were having inadequate pain relief. Anticholinergics, Benadryl. How many times have you seen an elder come in who takes Diprovan for overactive bladder? That's a pure anticholinergic, okay? Causes delirium. So if grandma comes in and she takes Vesicare or any of those kinds of things, you probably need to stop it, at least temporarily. Benzo, always the wrong answer. And it's the answer that the nurses want you to give them when they call and say, Mr. So-and-so, I need some Versed, I need some Ativan. Always the wrong answer. Right answer for someone who's seizing or someone who's in DTs. Not for somebody who is delirious. Because here's what happens. They get quiet. They do get quiet. What happens when they wake up? They're worse. So you actually make the delirium worse. So you're better off trying something else, okay? Liver failure can cause hepatic encephalopathy, can make you delirious. So can renal failure if you have SIRS or sepsis. But really think about anything can cause delirium. Patients don't bother to read the textbook, which I think it should be against the rules. So if just think locally. If this is delirium, what could be going on that might be causing the problem? All right, so the CAM, or the Confusion Assessment Method, actually was designed by a psychiatrist for non-psychiatrists to use. And since none of us are psychiatrists, it's a good thing to think about. It looks at 4 things. This is what you actually would use for somebody on the floor. It looks at, is this an acute onset? And so if they were GCS 15 this morning, and now they're a GCS of 8 or 9, the answer would be yes. Or do they have a fluctuating course? So if the patient is different from baseline, the answer is yes. Okay, so you have to have number 1, and you have to have number 2. So they have to have inattention, which means that they can't pay attention to you. So you ask them, all right, Christina, I'm going to spell something for you, and I want you to squeeze my hand every time you hear an A. Yes? Okay, should I do whatever?
I'm panicking.
A, B, H, 2 errors.
You said age.
They make more than 2 errors, but they're not paying attention. Okay? So, and that's really kind of what you're trying to do. These are also people that they're watching TV, and you say, Christina, look at me. Christina, look at me. Christina, look at me. And they won't pay attention to you. Okay? So do they have number 1, and they have to have both of these. Okay? And then, do they have an altered level of consciousness? Anything other than awake and alert, GCS 15, calm and collected, is a yes. So they have to have 1 or 2, and either 3 or 4, which means that they have disorganized thinking. So you ask them things like, will a stone float on water? Does 1 pound weigh more than 2? Can you pound a hammer with nail with a hammer, and are there fish in the sea? So simple questions that anyone should be able to answer. So if they make more than 1 you have delirium. That takes you about 2 minutes to do. Get done. So this is very long, okay? If you're in the ICU, you add the RAS to make sure that they're not too sedated. So they have to be like a -2 or above in order for you to be able to do this. So one of the things that we do in the ICU, we keep people way too sedated. You need to be awake more. You need to be awake and interact with their environment. Okay? So the best treatment for delirium is not get it to begin with. Okay, so to prevent patients from becoming delirious from the get-go. And that can be kind of hard depending upon where you practice. So doing non-pharmacological things, because no pharmacological intervention improves outcomes or actually stops delirium. It treats the behaviors that make things challenging and keeps patients from being able to interact with the environment. So try and figure out if there's an underlying cause. If they have a UTI, to treat the UTI, get the catheter out. Whatever it might be, if they're dehydrated or malnourished, whatever, to fix those sorts of things. Try to remove or reduce anything that might be contributing. So if they're in pain, treat the pain adequately. They don't have to be completely pain-free, but they should not be wanting to scream and agony. Make sure they're not dehydrated. Make sure their electrolytes are not abnormal. Hypoxemia, obviously, pretty obvious. And I'll tell a story on, it happened in SICU probably about 20 plus years ago. There was a patient who had a neck dissection, who had been restrained all night long, had been getting out of bed all night long because he was just confused and trying to get out of bed. So come on Saturday morning, I'm the charge nurse, and the nurse taking care of the patient says, I think this patient is inadequate. This is back before they actually had continuous pulse oximetry. Okay, so we didn't always have continuous pulse ox. And it's like, well, why do you think that? I was trying to get out of bed. So it's like, I think there's something else going on. You know, let's get a blood gas on and find what's going on. He's acutely hypoxemic. Expanding that until he dies. Okay, so don't underestimate hypoxemia. That should be one of the first things that you take off the table. All right, and also, do they have a high CO2? You know, if you are hypercarbic, you will have alterations in behavior, as will if you are hypoglycemic, right? If they are severely anemic, that can cause some issues because you don't have red blood cells that are getting oxygen to the brain, and then of course if they have infections. Now, other things. Now, this is really easier to do on the floor, more challenging to do in the ICU, especially SICU, but having things that are familiar around the patient so it helps to anchor them in the here and now. So, familiar objects. So, maybe a picture of the family, or if they like to listen to music, how the kinds of they listen to. Letting the family stay with the patient. Because, trust me, they don't know us from Adam. All they know is that we might be trying to hurt them. So especially since we're the ones who fasten them down to bed, do ugly things to them, make them hurt. Families staying at the bedside are much more effective at keeping patients calm and out of restraints. Out of restraints is your goal. I have never understood why someone who's quadriplegic is restrained. Do we ever see that? And why is someone who has got GCS of 5 need to be restrained? They don't. Sleep hygiene, okay? That means TV off, lights off, phone off, computer off, brush your teeth, wash your face, put your PJs on, and go to bed. Most of us have some sort of routine that we do before we go to bed. And part of that is telling your brain it's time to go to sleep, all right? How often have you walked into a patient room and the television's been on all night long? How many of you guys sleep with the TV on? That's bad for you in case you didn't know. Because that light that you're kind of over, you can turn off melatonin. Non-verbal music or white noise. I like listening to the ocean at night. Not running water, then we should have to get up to the bathroom, right? But the ocean's okay. Get the patient out of bed. I want people out of bed moving around. If you lay in bed all day long, are you sleepy at night? No, you're not. So I like patients up in the chair, moving around, walking if possible, because activity not only improves outcomes, but also helps you be tired at nighttime, okay? So relaxation techniques, if they're able to do that. A clock that has the right time and the right date, and you can read it without your glasses. All right, so you guys who are young, you don't have to wear glasses yet. Your day will come. And if you have a clock that's got little tiny numbers that you can't read, then you can't tell what time it is. And if it's got the wrong time, That really kind of screws you up too. And if you have a calendar on the wall that has the wrong day, you're really behind the ball, all right? Earplugs may help for noise in the ICU, and actually they're cheap. So putting earplugs in patients at nighttime to help decrease the noise is actually a really good thing to think about. It's cheap. Put them in at nighttime. Make sure you take them out in the daytime so that you know what's going on, and go on about your business. So if you have somebody who is really violent, managing those behaviors can really be very challenging, and sometimes can put you in danger. We actually had an intern, oh gosh, probably about 7 or 8 years ago, that some patient like Launius actually got her head on and pulled her hair out. So it can be really challenging. And so, and I recognize that because, you know, this is kind of pie in the sky, but it's things for you to think about. So restraint should really be your last resort because it actually can prolong your delirium. It also keeps you from mobilizing the patient and allowing the patient to reposition themselves in bed, which actually, in case you guys didn't know, if you change position like every 90 minutes when you're in bed at nighttime, okay? You don't really realize that, but you change position all the time. So it's better to have someone they know at the bedside to help, you know, keep them in the here and now, and then try to keep them back on a day-night schedule, have them in your environment quiet at nighttime, and put their bed towards the window, okay? So when I was still at the bedside, I used to do it all the time. People would like walk in the room and say, where's your wife's bed like this? You see outside, even if you just look at the wall, which is not very helpful. So giving the patient medication does not improve outcomes, does not actually terminate the delirium, but it helps the behavior so that you can get them out of the restraints and get them more on a day-night schedule. Frequently what happens, once someone is able to sleep, a good amount of sleep, the delirium usually gets much better. All right? So, there is no single drug that's better than others. Depending on what's going on with the patient, there might be better choices. They're all off-label. There's no FDA-approved drug for delirium. All right? So Haldol is the old standby. It's been used for years. The problem with Haldol is it has a lot of extrapyramidal effects. So if somebody has Parkinson's disease, you'll really give them bad shakes. But we almost never give enough. So if you actually read the literature, it says to give the patient 5 to 10 milligrams every 20 minutes, which is up to 30 milligrams an hour, until their behavior is where you want it to be. And then you give them a quarter of that dose every 6 hours. How much do we give to patients? 5 milligrams every 6 hours. So if you're going to use Haldol, which you can get PO, IV, IM, you give it rectally, you know, so if you've got someone that can't take something by mouth, you could, you know, think about doing it that way. So you can also, I mean, think about not giving patients enough. You can see Torsade, which is really the worst thing to have. It is a D2 receptor agonist, an antagonist rather, so it blocks the dopamine receptors in the brain. Now, the atypical antipsychotics also are D2 antagonists, but they're also 5-H2 antagonists. So this is the Seroquel, Geodon, Risperidol, Zyprexa. These all have similar efficacy as far as behavior is concerned, and they tend to have fewer side effects. So Seroquel is very sedating. So it's good at nighttime for elders to help them sleep. It also has diffuse extrapyramidal effects, so if you have Parkinson's disease, it doesn't make you shake too bad. Geodon is very sedating. Zyprexa is also pretty sedating, okay? So just think about what would be the best thing for the patient. And keep in mind, if you start somebody on something for to treat their delirium behaviors, they won't need to be on that for the rest of their lives. You need to take them off of that once their delirium has been terminated. So let's see, so I talked about the Seroquel. The Risperidol is relatively non-sedating, it doesn't really have a whole lot of kinetic effects. Zyprexa is pretty sedating, as is Geodon. My dad actually got Geodon when he was in the hospital. I walked in to see him the next morning. I could not wake him up. I thought, what the hell is going on? I went out there to the station, what's wrong with my dad? I can't wake him up. Well, he got Geodon because he got delirious for that time. It's like, wow, let's not even do more Geodon because he slept for 36 hours. All right, other things to think about. If you have somebody who is in hypoactive delirium, giving them a stimulant along the lines of Ritalin or Concerta might be something to think about. Once you eliminate that they're not in status that belong to this, subclinical. So we've done that a couple of times. Sometimes it works really well. Sometimes it doesn't really work at all. So it's just something to think about. Because if you want that person to be interacting with their environment, if they're just like, you're really not getting anywhere with the patient. Valproic acid Depakote increases GABA, so it helps to suppress the excitatory NMDA. It's really good for patients who've had TBI, who are disinhibited because of their head injury. And it can be sedating if you have them on a pretty high dose. It's something to think about. It does have a black box warning for hepatotoxicity and pancreatitis. You can watch that. I don't know if that's somebody to kill someone. Depakote. My dad actually wound up with Depakote. It worked really well for him, and we were able to take that out of him. Things to avoid: benzos, no place in delirium. If nurse calls and asks for a benzo, you should say no. Go see the patient. Okay. No intern should be able to prescribe a benzo for someone unless they're seizing or in active DTs. Cholinesterase inhibitors like Exelon, if you think about it, because you have decreased acetylcholine levels, if you block cholinesterase, that should improve outcomes. Actually, they increase mortality, so they actually stopped a study that was looking at that, so don't use that. However, if patients come in and they're demented and they're on Exelon patch or PO, then you can continue that. Something to think about if you've got someone who's delirious and you're really having trouble. You can think about maybe consulting psych, especially if you have geri-psych, because a lot of times these are older patients. Other things to think about, maybe neurology or gerontology, which I think we have here now, or intensivist may be helpful in coming up with some options you had time not considering. So here's Miss Loretta. So she got admitted to the hospital. She had UTI. We treated her for that. Put her on a day-night schedule. No restraints. Her daughter, who was a nurse, which is actually kissing down, to take care of her patient, stayed with her and did a really good job. Her sensorium actually cleared up about day 2 of her antibiotics. She's able to go home with her daughter, which was a good outcome, not off to a nursing home. So something to think about for delirium is that if you don't look for something, you can't actually see that it's there. Use the CAM or CAM-IC to help confirm your diagnosis. Don't do something that do that, so known precipitant if you can help it. If delirium is present, we suspect that's present, we want to do something about that. And then communicating with the family and nursing staff is really important, because here's the thing. Frequently, what you do isn't going to work just like that. And this is a very distressing thing for families to have to deal with, and it's hard for nursing staff to deal with. So if you explain to them what your treatment plan is, why you're doing this, what you're expecting to see, and how it's going to progress, you have a lot better chance of getting nursing staff to buy in, and the family to understand what's going on, and feel a little more comfortable with things that are wrong with the loved one. All right, anybody have questions? All right, well, thank you very much.